Well, welcome back, everyone. I'd like to continue my series of lectures on experimental studies. We've been talking about randomized controlled trials. We've been talking about how their measures of association from such studies should estimate very well the true causal effect of a treatment that's being compared, say, to a standard of care, a new treatment versus a standard of care. What I'd like to do now is to talk about some ethical issues involved in randomized controlled trials. Now, ethics is something that is an issue for any type of study, whether it's observation or an experimental study, but it particularly refers to experimental studies because remember the defining feature of an experimental study. The investigator is deciding whether a person is receiving, say, a new treatment or a standard of care treatment. The patient isn't making the decision. The patient's primary care physician isn't making the decision. It may be the epidemiologist in some back room flipping a coin that's making the decision that this patient's going to get a new treatment and this patient's not going to receive that new treatment but is going to receive a standard of care. Now, we've been referring to these as randomized controlled trials. When they're done in a clinical setting, they're also referred to as randomized clinical trials because we're talking about the effect of a treatment on some outcome, essentially among people who already have the disease. Now, in such studies, when you're talking about randomized trials in clinical settings, we're essentially comparing some new treatment to the best treatment a person would have received otherwise. That's what I mean by the standard of care. Ethics requires that. We can't assign people to a randomized clinical trial and to give one group of people a new treatment and not to give the other group anything whatsoever. Medicine requires and ethics requires that we treat the patient in the best manner in which we could treat an individual. And that's going to bring up some ethical questions to the investigator when he does or she does randomized controlled trials. Now, at the end of the series of lectures, I'm going to give you an example of a randomized controlled trial that's not done in a clinical setting, but it's done in a population setting. There, in population settings, these randomized controlled trials are usually testing preventive agents to see if some exposure, some treatment might prevent disease from happening in individuals. So I mentioned in the last series of last lecture how I'm taking an aspirin in the morning because of the recommendation of my primary care physician. It's because investigators have done experimental studies, randomized control studies in the past, where people without disease, people of my age, were randomized either to take a low-dose aspirin or not to take a low-dose aspirin, and to see which group had better outcomes, which groups had, say, less heart disease. The hypothesis that was being tested that is taking aspirin among healthy individuals might prevent future heart disease occurring in those individuals. Now, in those types of preventive studies, where you're not comparing a new treatment versus a standard of care, you're essentially comparing a preventive agent like taking an aspirin to the alternative of not taking the aspirin. In such studies, the alternative group is often given a pill that might look like an aspirin, might taste like an aspirin, but does not contain the ingredients of the aspirin. They're given something called a placebo pill. And we'll be talking about the roles of placebos in one of the lectures that I'll be giving in this sequence. But for the time being, let's focus on the randomized clinical trial, comparing a new treatment given to people who already have a disease, say they've been diagnosed with heart disease or they've been diagnosed with cancer, and what we wanted to compare is a new treatment versus the best we could give them normally, the standard of care. And in these randomized trials, again, we're talking about people who are assigned at random to receive the new treatment or the standard of care. Now, here's where the ethics come into play. This is the word I'd like you to go home with today, equipoise. It refers to the ethical dilemma that the investigator is facing when they do a randomized trial. Let's suppose you were unfortunate enough today to develop chest pain, severe chest pain, and you were concerned that you might be developing a heart attack. So you called for an ambulance brought you to the hospital, and you were conscious through all this, and you were being rolled into the emergency department. And suddenly then you see a physician coming into the room to examine you, and you might feel at ease saying, great, I've made it to the emergency department of this hospital. I'm in the good hands now of this treating physician. I managed to survive the the time between when I developed chest pain until the time I arrived in this hospital. But let's suppose you're observing this physician and he's asking you about your history, he's asking about describing the pain, where it's radiating and things like that. And then you see him sort of scratch his head, reach into his pocket and pull out a coin. And you see him throwing it into the air and catching it and looking at it. You might become concerned. I might ask, why are you flipping this coin? Well, if the physician says to you, I'm not sure whether I should give you this treatment or that treatment because I think both of them could be equally good and equally bad for you, and therefore I'm letting the coin decide which ones I'm going to give to you. At first you might say, gee, I want a new doctor. I want a doctor who knows what they're talking about. But if that lack of certainty really reflects what medical knowledge says about a person like myself with chest pain, in my situation, whether one treatment is just as good, just as bad as another treatment, in that situation, a coin flip is an ethical thing to do. So, and to in other words, not to compare to the randomized controlled trial, when are you justified to randomly assign people to receive a new treatment or a standard of care? The investigator has to be in a frame of mind when they talk about the pluses and minuses of the two treatments they're comparing, the risks and the benefits. They have to feel that they balance each other. They have to feel ethically sound and have sufficient evidence that the expected benefits from giving the new treatment to some people are essentially equivalent to the potential doubt and the expected harms of giving that treatment. That's the state of mind the investigator has to be in to justify ethically doing a randomized controlled trial, to justify letting a coin flip, a randomized event decide whether a person receives one treatment, a new treatment, versus another, a standard of care. And equipoise refers to that frame of mind where the harms and the benefits seem to equal each other to justify letting a coin decide what type of treatment a person is going to receive. Now, when we talk about equipoise, not only does it pertain to the investigator has to feel ethically sound, and I feel justified in giving this treatment, this new treatment, to half of my people selected at random, and not giving it to another half selected at random. But that equipoise also has to pertain to the individual patient themselves. I have to be approached by the investigator, and I have to give my consent, my informed consent, for enrolling in this study. That investigator has to explain to me all the potential harms, all the potential benefits of receiving the new treatment versus receiving the standard of care. He or she has to argue to me that this state of equipoise really does exist, because I have to be in that state of equipoise to enroll in a study, to give that investigator my consent, to let me be one of his subjects in their study, to let a coin decide how I'm going to be treated. And chances are I'm going to ask my physician, what do you think? This investigator wants to flip a coin to decide whether to get some new treatment or some standard of care. He says that the harms and the risks balance out each other. I might need your permission to enroll in this study, or I might just want to know your opinion on this. And chances are very good that the investigator can't talk to me unless they first get the approval of my treating physician, even to come to me to try to pitch this trial, to try to enroll me in my study. So equipoise refers to many people involved in the study, the investigator and the individuals that are enrolled in the study. And the problem for the investigator is this period of time when you're not sure whether one treatment is good as another treatment might only exist for some short period of time. The window of opportunity for doing this study, the window of opportunity where the investigator, the patients, and the doctors treating for those patients feel justified in letting a coin decide whether a person gets a new treatment or a standard of care might only be for a short period of time. Once a treatment becomes part of medical practice, it might be very difficult to approach physicians and ask, can I talk to your patients about randomizing to this treatment or a new treatment? Those physicians whose permissions I might need to approach their patients might be well founded in the mind frame that this standard of care is the best thing to do. they're no longer in a state of equipoise. They're no longer convinced that this new treatment is going to be just as good, just as bad as the standard of care, and therefore is eligible to be tested. They might deprive me from the opportunity to talk to their patients. And that's what I mean by this window of opportunity for doing a trial might be very limited. Now, that's the ethics involved in a study. The other thing I'd like to point out in this lecture is the differences between the outcomes you observe in a randomized controlled trial and the outcomes you might observe in an observational study. Observational studies are going to be something we'll be talking about in a future series of lectures. But it pertains to this notion that epidemiologists sometimes label as looking at efficacy versus looking at the effectiveness of, say, a treatment. Efficacy is what you're going to be seeing in a randomized trial. A randomized trial is a closely monitored situation where patients are given either a new treatment or a standard of care under some randomized device. They're being followed very carefully. They're being examined very often. The study's being done in this somewhat ideal situation. So what we're expecting to see in a randomized trial is we'll get a valid answer, a valid conclusion about the true effect of the treatment given to certain people, only the people who were eligible for this randomized trial in this ideal situation. The ideal situation is going to enhance what we call the internal validity of a study. Randomized trials are less likely to have problems due to bias, problems due to confounding. We mentioned a little bit about bias and confounding in the last series of lectures when I talked about cross-sectional studies. I'll talk about them a lot more when I talk about observational studies because they happen more often in observational studies. But one of the nice features about randomized trials is they tend to have less potential for bias and confounding, more potential for giving valid results. They're describing the effect of the treatment in an ideal situation given to only one type of people, the people who were eligible for this study. On the other hand, effectiveness is what we're going to be looking about in the future lectures. They talk about the effect of an exposure in actual practice, in actual situations. There, you have a greater potential for biases and confounding, less potential internal validity. But what you do get in an observational study is perhaps more external validity. The measure of association you see in an observational study might be more generalized because you're taking more general types of patients in observational studies. This slide here describes what happens when you perform a randomized controlled trial. You want to know whether one treatment is better than another treatment, whether this new treatment is better than a standard of care. In your mind, you might have the types of patients who you think would be eligible to be in the study. You have to be a certain person with a certain condition, a certain disease. And you want to recruit these people. Not everybody who's eligible can be recruited. You might approach my physician and say, I'd like to talk to your patient, Fran Cook, to see if I can enroll him in this randomized trial. Because I think this new treatment is just as good, just as bad as the standard of care. I'm in this frame of equipoise. I'm hoping the new treatment is better, but for all I know right now, one is just as good as the other. But my primary care physician might say, I don't like that new treatment. I've heard about that, and I don't believe in it. I'm not giving you permission to talk to my instructor. So the people you recruit might only be a subset of the people who you'd like to enroll in your study. Then once you come and ask me, can I enroll you in my study, explaining to me the pluses and the minuses, I might say, no, I don't want to be in this study. And therefore, those who consent to be in the study might not be everybody who you would like to consent, everyone you were able to recruit. And even after that, the people you actually enroll in your study and randomize might not be everybody you consented. And I'll give you an example of that at the end of these lectures when I talk about one specific randomized controlled trial. The point being, the type of person who gets enrolled in a randomized trial is not a typical patient with a particular disease that you want to test this new drug in. And therefore, the generalizability of the results from your randomized trial might not pertain to everybody who was eligible for that, to receive that drug, because of the narrowing of the patient population, the selection process that went involved from going from everyone who was eligible to only those people who were randomized. I'll give you an example of a figure like this at the end of this lecture when I talk about an example of one particular randomized controlled trial. Well, that's what I want to talk about ethics in this case. Next time I'm going to be talking about another topic of randomized trials, so I'll see you then.